nice.
Good afternoon, everybody.
Yeah,
How are
good
you?
evening, Professor Munir.
Thank you. Welcome, Mr.
I think we have only.
It is just.
Shirisha is left still now.
Yes, I will just give her
Probably
a
she
call.
will be coming. She.
Good afternoon, everybody.
Good.
Good evening.
Good evening from Bangladesh.
Thank you. Welcome, Mr.
I think we have only.
It is just.
Ishta, do you think I'll share screen or I can do it later on? No problem.
If anyone wants to just check to the screen, Dr. Shamira, do you want to check the screen whether
Yes.
it's working or not?
I'll just try that now if I can. Okay.
Yeah, please.
So share. How's that?
Okay, I think it's gone. It's fine.
You can
Yeah.
see everything?
Got it. Yeah.
Okay, excellent. Good, good.
Mhm.
Professor Nazrul, do you want to just check whether it's
Just
working?
let him stop it then.
Yeah.
Pereira, can you stop it, please?
Sure. Just 1 second. How do I do that?
You stop share.
There is a one thing, stop something written, stop
Got
share.
it, got it, got it.
Yeah, I think that's okay. Let me try. So this one is mine. Share. I think it has come.
Not it.
Few seconds, few seconds. Now it's on.
Yes.
Now it's okay.
Yeah, yeah,
Ishta, can you see my screen?
yeah.
Okay, so now I'm stop share. Okay, thank you very much.
Just contact Sirisha and see.
You want me to contact her?
If possible, madam, please.
I will do that.
Madam, it is better to see you after
Okay,
a long
I will
time.
just with me and
No problem.
Okay. Yeah.
Thank you. Thank you very much. The COVID has taught us this thing, webinar and
Yeah, too many.
Yeah, but
The
madam,
Indians,
for
they
us,
say
it's too many.
3 webinar in one day in India.
India, I think most
Too
happening
many,
in
too
India.
many happening.
Yeah.
We have one tomorrow.
Yes.
She says
Same
supposed to start
thing.
first, no?
She's our first speaker, so
Yeah. So let's wait for 1-2 minutes.
yeah,
If she comes. Yeah.
1 minute to
Might
7:30.
be technically she might have
Hey,
difficulty to enter.
Sirisha, webinar, everybody is waiting. 7:30 Bangladesh. 7 India.
Yeah.
Yeah.
She thought 7:30 in India.
Yeah.
Okay, that was.
Yeah,
No.
sorry.
Okay.
So it's in Singapore, you are operating fully, Samira?
No. I mean, we're just starting to taper back to normal, but we're only at 80% still. It's very difficult with the social distancing.
Okay.
How about in Bangladesh?
It's still just, we are just started up. The cases are rising still, but we are doing OPD in a limited way. And we have started just routine surgery recently.
So Bangladesh, are you operating fully?
Not
fully,
yet, madam. Not yet.
Not fully, but some of us have started yet.
Three days before, I have done 4 trabeculectomy. That was waiting for 2-3 months. Emergency. They're waiting for many days. So I was started limited way.
What's the situation in US? It's different in different part of the state. State-wise,
Yes, very, very different depending on the city. You know, some cities it's, you know, maybe they hardly feel anything and they're up to 80-90% of operations. In other cities, they're going back to closing down completely, and they're stopping all elective surgeries again. So it's very interesting. It all depends on the leadership for each city. And you can see the evidence of good leadership, you know, a few weeks later. So it's
She
amazing.
has come.
Yeah.
Yeah, good evening.
Welcome, madam.
Yeah. Good evening,
Sorry, I
Shirsha.
think there was communication lag
But,
from my
but
side.
you are in the sea. You are in the.
Bangladesh.
You are beside the sea, huh? Good.
Yeah. I
Very
think
nice.
it's
Yeah,
time we can
take it.
start.
Yeah, let's take it. Better start.
So I'll just start sharing my screen.
I think others should mute their mics when others.
Bangladesh Eye Hospital and Institute is going to organize a series of webinars on ophthalmology. Ophthalmology Webinar 2020, this 19th and 26th of June, and 4th, 10th, and 17th of July 2020 at 7:30 p.m. Bangladesh Standard Time. Big names, great surgeons, passionate teachers, creative innovators, supportive peers of ophthalmology will be speaking on current trends, topics, managing difficult situations about their innovations. Join the webinar where you will have the chance to hear their thoughts, clarify your queries, and know what goes in their heads and minds.
Dear colleagues, thank you for joining the webinar on different platforms like Zoom, YouTube, and Facebook. And on behalf of Bangladesh Eye Hospital and Institute, I welcome you all. And I thank all the eminent speakers and panelists for joining and the webinar and accepting our invitation. I especially thank Professor Nazrul Islam for helping me to arrange this webinar and Arista Vision for the digital support to conduct this. And all the speakers are very much known to all of us, but I would love to just give them a little introduction to them. Professor Lingam Vijaya, she is the senior consultant of Glaucoma department in Shankar Nethralaya, and she is the professor and registered PhD guide of Dr. MGR Medical University, Chennai University. She was the president of Glaucoma Society of India, and she is a consultant of the World Health Organization, and she is member of many prestigious organizations in different capacities like Initiative for Management of Glaucoma and Education, and she has been giving lectures and presentation all over the world, and she has got more than 124 publications in peer-reviewed journals with many chapters in book. Dr. Shirisha Shentil, she is the faculty and head of glaucoma services in LB Prasad Eye Institute. She has got over 150 national and international presentations and more than 115 publications in the peer-reviewed journals. And she has also authored many chapters of book. She has special interest in the refractory glaucoma in adult and pediatric group and glaucoma drainage device. She has also received many awards like American Academy Ophthalmology Achievement Award in 2018. Professor Nazrul Islam, he is the chairman of glaucoma faculty of Bangladesh Eye Hospital and Institute. He is the current president of Bangladesh Society of Cataract and Refractive Surgeons. He was the president of Bangladesh Glaucoma Society. He's a board member of APGC, But I would want to emphasize one thing, that he has inspired many like me to come in the field of glaucoma, and he has great contribution in treating the glaucoma patient in Bangladesh. Dr. Arif A. Ahmed. He is Associate Professor of Ophthalmology in the University of Illinois College of Medicine, and he is a board certified in USA and Canada. He is the Medical Director of Glaucoma Fellowship in that institute. He has got more than 50 publications and book chapters in peer-reviewed journals and books. And he has got a published textbook called Advanced Glaucoma Surgery. Dr. Samira Pereira. He is the co-head of bioengineering and devices in Singapore Eye Research Institute. And he is the deputy director of MedTech office in SingHealth, which promote this promising area to all other specialties, and has disbursed 6 million of Catalyst grant fund. And he has owned more than 1.75 million as a principal investigator. He has 5 book chapters and more than 130 peer-reviewed publications, and he is regularly invited in different countries in different conferences to give his lectures. Professor Iftikhar Muhammad Munir. He is the Professor of Glaucoma Department in the Apex Teaching Institute of Bangladesh. He is a director cum consultant of Bangladesh Eye Hospital, and he has got many publications nationally and internationally, and has won award in the national conferences. And I would be moderating today's session. This is going to be live streamed on YouTube and Facebook, so you can watch it also over there. And please keep the questions in the question and answer box. I would like to invite our first speaker, Dr. Sirisha Senthil, to share her screen and make the presentation. Dr. Sirisha. Sirisha, can you unmute and share screen?
Sirisha, you have to unmute.
Yeah. Okay.
Good evening, friends. Can you hear me?
We can hear you.
Yeah, and you can see the slides as well.
Yeah, perfectly.
All right. Thank you so much. And it's a great pleasure to see all of you on a virtual platform. And thank you for the invitation, Ishtiaq and Professor Nazrul Islam. So we'll just move on to the presentation. It's a very unusual title for a topic. So generally it is like trabeculectomy and its modifications or complications and things like that. When Ishtiaq asked me to speak about a specific topic where how do you deal with scleral flap making and suturing, and how do you do that to improve the success rate of trabeculectomy, I thought that was a very interesting thought, and I've put together a few of my experiences, and I will share that. So I have no financial disclosures to make. So trabeculectomy is a very unconventional surgery where we have to fight between the excess healing versus decreased healing. So we do face a lot of problems, and we know that if something goes wrong, the error margin is very, very limited, and we can end up having serious sight-threatening complications, and sometimes they can be very unforgiving. And this is one reason why people have moved into, and we are looking at alternatives to trabeculectomy to see if we can do a safe surgery for our patients who already are suffering with a problem that is sight-threatening. How can we modify our trabeculectomy to make it safer? This is a question that all of us ask, and then we continue to ask. I don't think we have a right answer to it. Like Professor Penko always says, that 10, 10, and 10. So if you're able to do a procedure in 10 minutes, able to bring down the pressures to 10 millimeters of mercury and let it work for 10 years, it'll be a fantastic surgery. But I don't think we have an answer there yet. What do we need to do? We need to definitely improve the success rate by decreasing the fibrosis. So because we want it to work longer. At the same time, the methods that we use to do this, to improve the success, also can increase the filtration in the early postoperative period when the healing is not so much, and thereby causing hypotony and its related problems and complications. So what we modify is basically the way we make the flap, because the trabeculectomy is a guarded filtration surgery where we have a superficial scleral flap and we have an ostium, and the flap is sutured, and the suturing is something that we can try and adjust and modulate and modify so that we can allow the filtration to happen in a very controlled manner. So what all can we change? We can have the technique of wide area dissection of conjunctiva, which is something that all of us follow. Wide area application of mitomycin, a phonics-based surgery so that you have more posterior and diffuse blebs. A large scleral flap is something that I will discuss with you as we go by in a couple of slides, and appropriate scleral closure. And of course, it goes without saying that very tight conjunctival closure is something that is a must. So how do we modify and what precautions do we take when we are making a scleral flap? So the days when I started learning glaucoma surgery, it was days when the smaller the area that you dissect the conjunctiva, the less fibrosis and scarring you will have, and smaller the flap, the better it is. But today I think we differ from that, and we do make a large conjunctival dissection posteriorly. When I say a flap, it's not the anterior opening, but the posterior dissection that we make, and a broad-based scleral flap. This is something that I do. And if we actually notice the flap, so when we say conventional 3 into 3 millimeter scleral flap, I don't think I make it so small. I make it 4 into 4 or sometimes even 5 into 4. That means the base is quite broad, and posteriorly, of course, because you're making a phonics-based incision, you generally don't go beyond the insertion of the superior rectus, which means it can't go beyond 5.5 or 6 millimeters. So usually it is a 5 into 4 or a 5 into 5 dissection of the scleral incision of the scleral flap. We do avoid perforating vessels because in case you can't, we dissect, but we'll have to take real precautions to be able to cauterize them, not cauterize them too much, at the same time not let it bleed, because you know when there is too much of bleeding, that will definitely induce fibrosis. Half thickness, depending on the scleral thickness, whether it is half thickness or 1/3 thickness is okay. Different people follow different things, but for me, conventionally, I use a half thickness scleral flap. And triangular and rectangular flaps are the commonly used ones, but I personally use a rectangular flap. I think it's because it's easier. Number two, the dissection is more predictable according to me in my hands. So why do we use a wide base? I think wide base is very important because if you make an adequate size ostium, you require adequate amount of scleral overlap on either sides of the ostium so that you don't have too much of an anterior filtration. Whatever we do, we should try and avoid having an excess anterior filtration, because excess anterior filtration is the one that actually leads to thin cystic blebs that are overhanging, or dysesthetic blebs, or even if you have a good bleb posteriorly, the anterior portion can become very thin and cystic. So you want to avoid that. And a wider area of fluid drainage posteriorly will also give you a very nice and a diffuse bleb. Sometimes you don't even see any elevation. It just looks like as if some amount of chemosis is there in these strap patients, and you see good pressure control in these eyes. Whereas if you make a very anterior, the base, if it is shorter, and if it is kind of a triangle which is much more posterior, you have too much of an anterior drainage because of the lesser amount of overlap that you have anteriorly. Also, when you're making a stoma, the ostium that is there, you can't make it very large, and with less amount of overlap on either sides will obviously lead to an excess anterior filtration. So that is something that we have to definitely take account of. So this is what the circle here actually shows you what I mean by a overlap on either sides. So by doing that, we definitely can decrease the amount of anterior filtration that happens in these eyes. Quantity of filtration is important. That means we do want them to filter well. At the same time, you cannot have excessive filtration because you should try and avoid it to prevent hypotony in the postoperative period. For that, size of the flap and the size of the ostium and the amount of overlap is something that is very, very important. Flap closure. This is a question that most of the people ask. How many sutures do you apply? How do you decide that you use a single suture or you use multiple sutures? How do you decide on a one releasable versus multiple releasable, and how tight should your releasables be? These are questions that are commonly there for all of us. And I think each of us use a judgment and also based on your own experience that you have altered certain things. And when I say that is very, very applicable to each and every surgeon, because I'm sure each of us is doing a certain way because of what we have learned and what works best in our hands. So if somebody asks me when I use only a single suture, most often in children, I use a single suture. I don't use additional sutures in them. If I'm doing a combined trabeculotomy and trabeculectomy, in a combined surgery, when I'm doing a phacotrabeculectomy, I again use a single suture where I know that these eyes will be able to, in the first category, these eyes will be able to take the early excess filtration very well, and generally heals quite well, and there is not much of a problem. I don't use releasables in them because we don't take them up for an EUA in less than a month's time. Combined surgery, again, because of the scarring and things like that, it happens even otherwise filtration is not too much. So they do work very well with a single suture. 3 sutures, fixed sutures, is extremely rare. I do that if I find that some reasons, very rarely you have patients where after a single suture or an additional suture also you have excess filtration on the opposite side, or if I have a shortening of the superficial scleral flap, either because of excess cautery or if the tissue itself is abnormal, then I may put 2 fixed sutures. And if you do that, you may want to do a laser suture lysis at a later time point, but generally I avoid doing it. What I generally do is a 1 fixed suture and 1 or 2 releasable sutures. And this is something that most of us follow. And the tightness, of course, the apical suture is just an opposing suture. It is not very tight, but the releasable sutures are quite tight. Whether it is a triangular or rectangular, it works the same way. Resistance of flap closure to me is one of the most important determinant which allows the amount of fluid and the intraocular pressure that you see in the postoperative period. And releasable sutures are definitely something that I use. Adjustable suture is something that I have done just a couple of times, but the problem with these adjustable sutures is that you will have to manipulate it through the conjunctiva with a non-toothed forceps, and if you're not very careful or if your conjunctiva is thin, you may end up having a buttonhole. So the difference between adjustable and releasable sutures is that in a releasable suture, you have one edge which is exteriorized and that could be used to pull it out. And for an adjustable suture, you don't have that edge there. You just have just the way you put a releasable suture, but the edges are, both of the edges are trimmed out. So they can be loosened at any time point in the postoperative period using a special type of forceps. But like I said, this is not something that I routinely follow. Laser suture lysis, of course, if you have fixed sutures, you may want to do them, and definitely not before 2 weeks after the surgery. Very rarely, most often with a massage itself, we should be able to bring down the pressures in the first 2 weeks postoperatively. Releasable sutures is where I thought maybe I'll spend a couple of minutes. Releasables, we can do both with the phonics-based as well as a limbal-based releasables. 2 techniques of releasables is what I generally use. One is a straight suture that you place on the cornea, and then you do the regular 4th row releasable that we normally do. We can do this even for the phonics-based, the limbal-based conjunctival opening also, but there you may need an assistant to be able to hold your conjunctiva so that you will be able to manage to do it. So what do I mean by a straight releasable? You just take a bite on the cornea, which is straight, and then you go ahead and do a loop suture on the opposite quadrant or on the same side. Past couple of years, what we have been doing is a loop releasable, where sometimes you may not want to, maybe about 10 to 15% of my trabeculectomies may not need a release of a releasable at all. Their pressures are so well controlled that you don't want to touch them. And especially if they're outstation patients, you are a little worried of this loose suture that is hanging on the cornea. Although you have made it intrastromal, sometimes the edge can get exposed. So this loop releasable actually gives you an advantage of placing a releasable at the same time. If you're not removing it, you have good epithelium that covers it, and you can leave it like that, and generally it doesn't get exposed. So that is the only difference, but this is how we take a loop on the peripheral cornea. I'll just share a video which shows the same suturing. So we just, it's just the opposite way of taking a bite. And I generally use the same side corneal suture and the same side scleral suture for the ease of doing it as well as for the ease of releasing it. The rest of the technique is the same. So if you see, just this loop is available on the cornea, and when you require it, sometimes it gets epithelialized. You can just use a sharp needle to just pull that out, and then you can release it whenever you require it. And if you don't need it, you can leave it like that. It just gets buried. So it doesn't trouble you at all. Of course, although it is about suturing that we are, the scleral flap suturing that we are talking about, we cannot emphasize the importance of conjunctival closure is extremely important. So different techniques of conjunctival closure. So I generally try and combine these two. For example, if I'm doing a phonics-based surgery, let's say in a patient with juvenile open-angle glaucoma, and I put 2 releasables and 1 fixed suture. Generally, phonics-based, the limbal-based conjunctival opening and closure in my hands is associated with little more filtration compared to a phonics-based. I also believe that in a phonics-based conjunctival closure, when you make a tight closure in the anterior end, that also gives some amount of resistance. Whereas in a limbal-based closure, your suture line of the conjunctival suture line is much more posterior. So that resistance of the conjunctival closure is not there. So in these patients also, I make very tight scleral flap closures because I know that these eyes are more likely to have excess filtration in the early postoperative period. So be it phonics based with wing sutures or a limbal based with continuous sutures, whatever technique you do, you will have to judge the way it behaves in your hands before you decide on how many sutures you require and how tight your sutures should be. I'm not going to the details of the conjunctival closure, but bleb morphology is something that's very interesting. And this is something that I would like to always discuss about. If you see here, this is a diffuse bleb that you see the first picture, which is a phonics-based, typical phonics-based conjunctival opening that we make with 2 or 3 wing sutures. And this is again a very diffuse bleb that you have a very posterior limbal-based opening that I have made about 7 to 8 millimeters posterior to the limbus. And this is a modified limbal phonics based, where it is a phonics based, but leaving behind 1 millimeter of the anterior conjunctiva like a frill and then closing it. This also gives you a tight closure, at the same time gives you a posterior flow, or an altered about 3 or 4 millimeter conjunctival flap, especially in scarred conjunctivas where you cannot dissect anteriorly. You can do that modified. So most of these techniques that we do, if you do a good posterior dissection and flap closure in a way that you have more of a posterior flow, any of the techniques that you follow, you may have a diffuse bleb. So you don't have to worry about which technique is better. So just to summarize that what you do is based on your experience, whether it is a limbal based or a phonics based, it's fine. Whatever you do, what works well in your hand is all right. But I think what is important is the way we close the scleral flaps should be very appropriate depending on filtration that happens on the table, as well as what is your experience in certain kind of patients. So just to reiterate the point that we need to definitely have trabeculectomies that work longer. Having said that, we definitely have to take precautions to prevent early postoperative hypotony so that we don't end up having complications in these patients. And all of these points that I have highlighted is what I have just discussed, that starting from whether you take, whether it is the superior rectus that you take or a corneal traction suture that you take until you close the conjunctiva, every step is very important and we need to be meticulous in everything that you do. Also, the post-operative follow-up and when to release these sutures and do we need to do it or not is something that we have to be very, very cognizant about. Thank you so much for your attention.
Thank you, Dr. Shirisha. That was an excellent presentation as expected. I mean, we're going to have a lot of questions, but we will have the questions at the end of our all the presentation. So I think it's my presentation time now. I am going to be presenting management of overhanging bleb. Am I visible?
Yes.
Yeah. So I'm sure that if we could do surgery like Dr. Shirisha or Professor Vijay, we would not have this sort of blebs. And actually, the way things are moving towards mix, this sort of overhanging blebs will not be seen some years later. This usually associated with more concentration of MMC and prolonged times. And there were times that surgeons were using for more than 5 minutes or 5%. And also some of them were associated with doing tenonectomy, even with the combination of MMC. And the extent of the overhanging bleb can vary from very minimum to a big, large overhanging one. And the symptoms also vary between patient to patient, and the amount of the overhanging bleb from being asymptomatic to just foreign body sensation tearing to even decreased vision. Because if it comes down up to the pupil, then it can obscure the our vision. And there has been many papers showing that the histopathology of this overfiltrating bleb, Young and Ott showed that there was neoplasm like hyperplasia, which was covered with atrophic squamous epithelium, but there was no evidence of inflammation or tumor. Rather, there was fibroblast in these overhanging blebs. And the issues with these overhanging blebs, that because it is avascular and the lid continuously presses over them, it becomes more hanging, and there are possibility of bleb leak, perforation, and leading to bleb infection. And of course, there are some cosmetic problems with this. So the indication of the surgery would be, if there is leak, hypotony, too much exposed bleb leading to lid retraction or leg ophthalmos, and compromised vision, and if there is repeated infection because of this. So there has been many publications of how to manage this in different ways. The commonest of the things that we use is in literature, it shows that they have tried with cryo, argon laser, ND, YAG laser, injecting autologous blood in that overhanging part and giving compression sutures like this. So what's basically done is they take 1 or 2 suture between the filtrating part and the overhanging part. But the problem with all of this is that there is chance of again becoming perforation from those parts, and it becomes overhang again. So the main approach is excision of the overhanging part and covering it with conjunctiva. So if it is a small defect, we can just make advancement flap to cover that area. If it is a moderate one, we have to give some relaxing incision or rotational graft. And if it is a large defect, we have to have free graft autograft or cover it with a sclera. This is a patient that I'm going to share. This was a one-eyed patient, and the other eye was lost from a bleb infection, which was a similar sort of overhanging bleb. Trab was done 6 years back, and there was leak, and IOP was very low. And since it covered the visual axis, visual acuity was 160. So this is the patient that it looked on the table. My initial idea was to just excise the devitalized overhanging part, preserving as much as possible of the healthy tissues. And I took all the precautions that not to harm the scleral flap, whatever was there. So I planned to excise the superficial part first, and it just came up very easily from the cornea. As you can see that after removal of the superficial part, I could see that actually there was no scleral flap, superficial scleral flap. Rather, there was some necrotic scleral tissues and some fibrous tissues over there, and the ciliary body was exposed in that area. So I planned for a scleral graft over that area, and considering that this was the only functioning eye with a very low IOP, so I planned for a scleral graft. This was a donor sclera which sutured to that area. This was to prevent the future hypotony, and we have to be very careful that we undermine all the sutures and not to make it too tight, because that way the filtration will not be there. Again, the IOP would be raised. And then I tried to undermine the conjunctiva to get it over covering that sclera, but it was not possible. So I planned for an autograph. I'll just fast forward this, take conjunctiva from the inferior part. And we have to be very careful that while taking it to cover the sclera, that limbus part is orientation is maintained. Just cover that suture that conjunctiva, some 4 sutures on that side, and intermediate sutures in between, and check that that part was watertight, just like trabeculectomy. We have to be very meticulous in this part. So the desired outcome was to have symptomatic relief, retention of blood function, maintenance of intraocular pressure, and cosmetically acceptable appearance. The patient did very well. The patient still comes to me. He has some pressure of 11/10 and visual acuity has improved and the patient is very happy. So thank you all for the patient's hearing. I would stop my video. Now it's Professor Nozrul. Sir,
Yes.
I think it's, yeah. Can you share your screen and present? Professor Nozrul is going to be speaking on glaucoma drainage device in refractory glaucoma.
Can you see my slide?
Yes, we can see you.
Thank you very much. Thank you, Dr. Shtiak, for your wonderful presentation. And of course, Dr. Shirisha did the same. And I'd like to thank our guest speakers and panelists, Dr. Bijoya, Dr. Shirisha, Dr. Pereira, and of course, my friend Ahmed Arif from USA. Well, my topic is glaucoma drainage device in refractory glaucoma. So all of us, we know, I don't have any financial disclosure, that what is refractory glaucoma? When the glaucoma IOP is not controlled with conventional medical, laser, or surgical treatment, even the traditional filtration surgery, we call it the refractory glaucomas. And definitely, we have some glaucoma that is really high risk group. Like if you do the surgery like trabeculectomy, cataract surgery, retinal surgery, corneal surgery, this group of people actually fails trabeculectomy. And if there is damage conjunctiva in chemical burn, pemphigoid, we have some inflammatory glaucoma, neovascular glaucoma, secondary glaucomas that also fails the traditional filtration surgery. Usually, this becomes the refractory glaucoma cases. We have different options for the management of refractory glaucoma. So today I'll talk on glaucoma drainage device, but definitely we have options of cyclophotocoagulation, cyclo G6 micropulse, ultrasound, ciliariplasty, even a mix. I think Dr. Pereira will give some light on it. If you see the big list, that all these cases, starting from neovascular glaucoma, retinal detachment surgery, traumatic glaucoma, idiopathic glaucoma, all actually indications, especially when the traditional surgery fails. But there is a debate. Should we do the primary or initial surgery, the tube surgery in this refractory glaucoma or high-risk group of cases? There is debate. Some people says this is a study in 2009 by Kwong and Nguyen. They said the tube as the initial surgery gives a better result in this high-risk group of patient. And they have said that it gives better result in controlling the IOP for a long time. Even in the very popular TBT study, we find that if we do the trabeculectomy or the tube, after 5 years, ultimately the tube groups had better result. So they had one surgery before, maybe trabeculectomy, maybe other surgery. So all the groups, ultimately after 5 years, it was found if you do the tube surgery as a second surgery, the results are better. But on the contrary, in a recent study published in March in Ophthalmology 2020, by Stephen G.D. and all, they found if we do the primary surgery, even in the high-risk group, with trabeculectomy, there is no much difference. So ultimately, I think it's the personal choice and experience of the surgeon who will do the initial surgery or will do after failure of the conventional trabeculectomy. The GDD, we have different kind of GDD in the market. Definitely some are bulbed, especially Ahmed bulb, and some are non-bulbed. Mostly the Barvelt is very popular in the European and American people. And of course, in this continent, we have very popular RD. We also use in Bangladesh. Recently, there are two non-bulb devices, Ahmed bulb, a clear path, and Paul glaucoma implant. In some difficult cases like the scleral buckle, we can use the Bolton, the socket procedure. And recently, the Molten 3 has come. It is also being used by many surgeons. For me, I use mostly the Ahmed bulb because it's easier for me. Now there is a question that we should use the bulb device or the non-bulb device. Again, there are a lot of studies on this. There is ABC study, the Ahmed Barbell comparison and other studies. It found that after 5 years, the Ahmed group has lower success of IOP control. On the other hand, the Ahmed group has far less complication in the post-op time. So both group has pros and cons, and ultimately it is the surgeon choice what to do. So my choice, most of the time I do the Ahmed bulb implant. In my cases, it is very easy comparative to Barbell and other non-bulb devices. It is comparative, plate is smaller, and it has single plate, it has double plate, it may be silicone like FP7 and FP8. It also polypropylene plate and different models, both the AC model and also the pars plana model. So there are different model on this. So, sorry. So I think the video is moving. Okay. So this is a short video clip of Ahmed glaucoma valve implant. It's my way of doing it. I use this 6-0 silk or the Bicryl for the corneal traction. Usually I mark the area where I'm give the incision. And usually I keep 1.5 to 2 millimeter conjunctiva free in the limbus as the stem cell. And also it helps me for the suturing of the conjunctiva later on. Usually I dissect both the conjunctiva and the tenons together so that it becomes better dissection. I'm getting the pocket with the scissor, and of course do a bit of there is the cautery here. And priming is very important for the bulb, because if our priming is not easy, that means that the bulb mechanism is not easy. So that bulb may not work. So we must do a priming for every valve. Then putting it and suturing it by 9-0 nylon here. But of course, 8-0 nylon or 8-0 polyene is good also. People are using it. You can use one suture or even the two suture. Usually I give two suture here, and I bury the knot in the eyelet of the valve. For the tube covering, I usually use the patient's sclera, the patient's scleral flap, the half thickness flap. And I do it the short tube, short flap method. That is, I make a 3.5 to 4 millimeter tunnel. This is a short tunnel. And I make the flap 3.5 to 4 millimeter. As a glaucoma surgeon, most people can do it easily. So I feel that people can do it different way. You can do a direct needle tunnel, but this way I feel it is comparatively easier and reproducible for my residents. So easily you can introduce the tube under the tunnel. And then making the track with the 23G needle by bent needle and going in the antechamber parallel to the iris, and give a little bit viscoelastic, so that not much, a little bit viscoelastic, so that it's become a bit deeper. And during coming, I'm giving a little bit enlargement of the outside, so that it helps me to introduce the tube. Only the external orifice, not the internal. So I'm using simple Moorfield forceps. People can use also the special tube made by the New World Medical. And every suture should be buried. Otherwise, there will be irritation for the patient. For the closure of the conjunctiva, I make 2 corner suture here, excuse me, and here, so that there is good apposition. And I'm using the 8-0 Bicryl for closure of the conjunctiva. And then I make the horizontal through and through the mattress suture from one corner to up to this corner. So let me forward it a little bit. So when I come here, I close the wound. So ultimately it gives a very good watertight wound and closure of the conjunctiva. So it is finished. Then if the eye is very soft enough, you can give a little bit of the viscoelastic, no problem. Now this is the young child. I am doing the primary tube in these cases because the child is under anesthesia, and trabeculectomy usually fails in these cases. The patient had several times surgery. So I am using the tube, and of course, as a child and in high myopic thin scleral cases, I definitely use the scleral graft. We do not have processed sclera, so I am taking the sclera from my oculoplastic colleagues, and we use it. Well, now is the open tube. Of course, you can use it. This is the tube and non-valved device. Most of the people, they use this, especially I think Dr. Arif, he will be in favor of this. And actually, when I learned the glaucoma drainage device in USA, in Newark Eye Infirmary, my mentors, Professor Robert Rees, Jeffrey Liebman, and Dr. Sosotelo, all of them, all the consultants, they used to use the bar belt. So what I learned, the bar belt is the best GDD at that time. I came back to Bangladesh, there was no supply of bar belt. So definitely I learned, the supply was only Ahmed. So I learned from Ahmed, and still for the long and many years, I'm using mostly the Ahmed. But we are fortunate that RD is available in Bangladesh. It is very, very low cost. It's only 60 to 70 US dollar, comparative to 500 US dollar of Ahmed or bar belt in Bangladesh. So definitely we are fortunate that we have the RD in Bangladesh. So the people who cannot afford the high cost, we are using the RD in Bangladesh. This is the RD implant. It's almost same like the bar belt. You can do under cover of the superior rectus and lateral rectus. Both the wings should be under the muscle. The wing is tucked under the muscle like this. And the remaining part is almost same. Only difference is that you have to occlude the tube because there is no valve here. So definitely you have to occlude the tube. Otherwise there will be hypotony in the first day. So occlusion is done by 6-0 Vicryl. And we should test it that occlusion is complete or not. Otherwise there will be hypotony in the second day. And after putting the tube in the antechamber, after covering it, you make 2 or 3 fenestrations. So in the first few weeks, there is some leakage and some kind of flow of fluid, and pressure should be less in the postoperative period. Otherwise, we have to give anti-glaucoma medication in the postoperative period. Recently, in the last 2 years, we are seeing that Ahmed Clear Path is the non-valve device. It is being used. It's now, I do not have any experience with this, but people are using it because it is very much malleable. Most important part is that you do not have to put under cover of the muscle. Simply put in between the 2 muscles, and just like the Ahmed, you put it and fix it with the two eyelets, 8 to 9 millimeter away from the limbus, and fix it. The other part is almost same. You have to tie again if you do not use the ripcord. But the company sometimes gives the ripcord along with the valve, so that if you use the ripcord, even then you have to you have to occlude the tube so that there is no hypotony. So lastly, this is my last video on Paul glaucoma implant. Actually, I brought a few pieces of glaucoma implant from Singapore, and I have used it. The beauty of this device is that tube is only 30 gauge, very narrow. So you can use it in many cases where the AC is shallow, even the angle closure glaucoma. So it is one of the advantages, and there is possibly hypotony is very less. You do not have to occlude the tube if you use the stent or the ripcord. That is the good advantage of this kind of non-valve devices. So on conclusion, I like to say that refractive glaucoma is not uncommon. All of us, we find the refractive glaucoma, but the management is not very easy. It's really challenging, and it's really the specialist job with some experience. And definitely when the vision is not very good, cyclophotocoagulation, maybe CPC or ACP or MPL, everything is fine. But when there is vision is good, then glaucoma drainage device is really a good option for the management of the refractory glaucoma. Thank you very much.
Thank you, Professor Nazrul, for the excellent presentation. We have a lot of questions coming for everyone. And I would invite Dr. Shamira Pereira. Can you please unmute and share your screen?
Okay. Can you hear me?
Yeah, Yeah, it's visible and we can hear you.
Excellent. That's great. Thank you very much. So it's a real pleasure to be here seeing you all virtually. And I must thank the organizers for an excellent presentation here. And thank you very much for inviting me. So I'm going to be speaking on trabecular meshwork MIGS. This is something I'm quite passionate about. I'm going to give you an update on where we are now with this whole very interesting area that's actually been around for a while now. And I've been interested in the evolution of these devices. So I'll give you my insights into how they've evolved over the time that we've had them. These are my financial disclosures, and some of these are the MIGS companies that I give talks for. Now, what I like about these trabecular meshwork MIGS is that they are, of course, they promise this better quality of life, but of course they are always very poorly cost effectiveness. And if you thought that the tube costs were high, all of these MIGS are much more expensive than the Ahmed valve, for example. The advantage of these is, of course, the much lowered risk, but the balance is that there's going to be a much lower reward as well. I think universally, what we do like specifically about these trabecular meshwork MIGS is that they're very elegant procedures to do, and they can be quite fun as well. Just to show you how these MIGS devices have affected my own practice, this is what I was doing in 2009. And you can see that there was doing quite a lot of trabs and phaco trabs in that time. And that number has massively decreased in 2017, despite the pie getting larger. And you can see that big green area, which is actually almost about half of my practice now, which is actually phaco plus MIGS. The ones that I'll be talking about today are the KDB, gap procedure, trabectome, the iStent, Hydrus, and the ABIC. And just to see where they fit in, I just thought I'd give you a little bit of insight into the other procedures that I won't be talking about. And those are things that have the Zen implant and the Santen Presoflow, which are given subconjunctival drainage, and the suprachoroidal devices such as the iStent Supra and the Miniject. As you know, the SiPass has been withdrawn. So these devices all share something similar about them, and they generally tend to be procedures that are combined with phaco, and they are better with phaco. The IOP lowering is better, and they're sort of insert and forget, because the areas that they're inserted to, we can't really do much about the scarring like we can do with trabs or the ones that are given the subconjunctival space. And the downside of that, of course, is that whilst we can't do much about these devices in that particular area, and we don't really know much about the scarring that occurs in that area, that means that we can just put them in and then forget about them. They don't really cause any problems with hypotony because you're always going to be limited by the episcleral venous pressure. And they don't affect the success of future trabeculectomy either because they're conjunctival sparing. And I think universally amongst all of these, they do have a very good safety profile compared to the alternatives like the subconjunctival device and the suprachoroidal devices, which can actually cause significant hypotony. So just to go through some of the devices in a little bit more detail, this is the portfolio for a Glaucoma, and you can see that the iStent came out in 2012. It's like a snorkel-shaped device, and then more recently they've introduced the iStent Inject, which is two devices that stick into the trabecular meshwork. And then very recently they have the iStent wide flange, and that's a modification of the iStent Inject, which actually has a wider area, so it's more difficult for it to be over inserted. Just looking into the future, they also have this iStent Infinite, which is actually 3 iStents, and you get unlimited amount of shots. That's what's called the Infinite, and that is supposed to have an even better IOP effect. There are some other things I have as well, which is the iDose, which is looks like an iStent, but it also has a slow release travoprost agent to it. And that's shown some impressive studies, results in those studies at the moment. Actually, it's quite interesting. And the Supra is a suprachoroidal device. So here's the original iStent going in. You put it in with an introducer and you slide it into the canal. It sits there very, very safely and sturdily. With the actual injector, you can take it in and out as well. And the idea is that it improves the trabecular meshwork outflow over a particular region. You generally put 2 in because the results are better, and you should keep them a little bit further apart because they will be draining separate areas ideally. This is what they look like when they're ideally put in, but of course there's a bit of skill to this, and they're very, very fiddly devices because they're very, very small to put in. These have largely been superseded by the other devices now, which I'll tell you about later. But in the initial study, they had very modest IOP lowerings actually. And they found that in this one study that shows the differential effects of putting 1 iStent 2 and 3 in, you can see that actually that you get much better IOP lowering with 3, but they settled on 2 with the iStent inject as the kind of sweet spot. But as you know, that they're going to come out with the iStent infinite, which is the 3 iStents in the future. Here's the iStent inject going in. This is a different, smaller device. You just poke it into the canal and then you fire it in and it stays just there. And you move along about 2 clock hours and then fire the second one in. You've only got 4 shots, but 2 devices. So you need to get them fairly far apart. Otherwise they're draining the same arc length of the trabecular meshwork. Not so useful. This is the Hydrus device, and it's actually the one that's lower down, the smaller one. The original one was the much larger prototype, which never actually went into production. And that has the advantage of not just bypassing the canal, but expanding the canal as well. If you look on the right side picture, you can see what it looks like once it's in there properly. And you can see there's some reflux of blood coming out of the canal. Now, the idea is that it would have a larger area of drainage, about 120 degrees, and you'd be more likely to catch those collector channels, which are the super highways where the aqueous can drain very, very quickly away. The picture on the left, which I'm toggling between 2 pictures there, shows the insertion of an iStent, an OCTA pictures of the drainage in the episcleral venous plexuses. And what we're trying to show is that in the area with the yellow band, which is where the iStent, where the Hydrus has been put in, you can see there's increased drainage after it's been put in compared to the other areas. Here's one of these going in a patient actually with angle closure. So this patient's got like only 1 quadrant left, and I'm trying to put the device in that area because the rest of the eye has got PAS. So I'm putting it into the canal here, and you thread it in along the Schlemm's canal. It should be very easy to thread in, but it goes behind the area of PAS. So as you can see here, it's occluded. So I have to get rid of that PAS. So what I do is that once I push it into the right position, I go back, have a look at it, and remove the PAS with a goniosternoculasis spatula here by revealing the device in that angle. The big question here is it going to work? Because we know that when there's prolonged changes to the trabecular meshwork, when there's PAS, the trabecular meshwork is not working beyond it. In this case, actually, it did work very well. I've shown my results at the top there, and whilst we do have some 2-year good results, with angle closure and open angle glaucoma, you can see that the angle closure is a bit more modest because I think that this device does develop PS like any of these things do. And we had used it, off-label use for this particular indication. Just look at the graph on the left. That shows the amount of occlusion that you get in open angle and closed angle. You see there's much more occlusion in the closed angle eyes, and that's with the G1 device as well. And we propose that it's probably the same with all these devices. There's going to be much more PS formation when you have these angle closure eyes. Now, I was very fortunate at one period to be able to evaluate a lot of these MIGs because we were doing studies on these MIGs and we were involved in collaborations with the pharma companies, and they were giving us these devices free. And I would consent these patients for a MIG surgery, a TM MIG surgery, but I would be able to choose which MIGs. And I wanted to see if I could choose the right MIGs for the right patient, depending on features of the patient themselves and the features of the angle itself as well. And my job at SNEC was to basically be the person who does these MIG surgeries and then reports back to the rest of the department, because it's just unethical really to have everybody in the department learning every single procedure along the large learning curve when we should be rationalizing how we actually use these devices. There are lots of devices out there, but it's very unlikely that many of them will be able to make it widespread. So we actually rationalize our devices to 1 for the subconjunctival space, 1 for the suprachoroidal space, and maybe 2 for the trabecular meshwork. Now, this is the original TM MIGs that invented it all. That's the trabectome, and it basically cuts through the Schlemm's canal with some electrocautery, and that's been again evolved through now to what you see on the right side of the picture, the goniostome. And here's some videos of how that works. And you can see it in the picture at the top left. It's slicing through the canal and opening up the canal by removing that area of the trabecular meshwork. Now, picture on the right, the video on the right, is actually the KDB, and that's basically a simplified version of the trabectome. Of course, you don't have the infusion like before, but what you're doing is excising a histological sample of the trabecular meshwork there, leaving open the back wall. Now, this is an interesting procedure because it's just a blade. It's actually one of the cheapest ones of the different MIGs that we have available to us. And the problem with the trabectome is it's very expensive to buy the device, and also every time you use a different head, again, that costs you as well. So the KDB was quite a nice way of making this cost effective. But of course, with these slicing procedures, there's always the worry that you're damaging the back wall as well. And would that lead to future scarring as well and limit the long-term success of these devices? The other problem with these devices is that when you're slicing through, you can cause bleeding. This is a patient who had quite a large bleed in the anterior chamber. And as you can see, it's got trapped behind the IOL. The blood's got trapped behind the IOL. But I suppose it's a testament to the fact that they do work, because the blood in front of the IOL actually drained away very nicely. And I didn't even have to do a YAG on that eye. It just cleared up by itself, as you can see on the right side. Moving on to some of the other slicing procedures. This is the TRAB 360, which shows you inject a viscoelastic and a small plastic tube into the canal and then rip it out. Basically, it's like a trabeculotomy. And on the other side, on the right side, you can see transluminal trabeculotomy, which is basically you pass a Prolene catheter through a small incision in the trabecular meshwork, and it goes round 360 degrees into the canal, and then you rip it out, thereby giving a 360 degrees trabeculotomy. Here's a video from one of my colleagues, Zeynep Aktas from Turkey, doing a gap procedure where she's incised the canal, has injected the Prolene suture in, and she's pushing it all the way around, and you can see it coming around the other side as well there. And just there, it's maintained the 360 degrees. You grab hold of both ends and you pull both ends through, and you can see that that will basically cause a trabeculotomy 360 degrees. Sometimes you can't get through 360 degrees and you have to do 180 on one side and 180 on the other side. Now, again, we'd like to see where these procedures will be particularly useful. It seems that this one may be the most useful treatment for pediatric glaucomas, and that's where she specifically uses this more commonly. And it's sort of replacing the goniotomy in many ways. Of course, there is some scarring, and you can see in this patient with younger patient with glaucoma, from steroid glaucoma here, there is some scarring in the later stages across the canal. Moving on to the last one I'm going to speak about today, which is going to be the ABIC procedure. This is something that evolved out of canaloplasty. So canaloplasty was a procedure where externally you put a Prolene suture into the canal, tied it off, and tensioned it so the canal will be opened. But they found that actually sometimes they couldn't go all the way around 360 degrees. And then they just had to give up. But these eyes still got some good IOP lowering. So they found that the simple effect of putting the suture in and putting the viscoelastic in would lower the pressure. So hence they moved on to this ab interno canaloplasty, which was basically with using a fiber optic device which goes through the canal. You thread it through, you know where it is, and then when you've gone around 360 degrees, you pull it out and inject on the way out viscoelastic, thereby expanding the canal. And the unique feature of this one is that it would also expand the episcleral venous plexuses, because it's the only one that targets that area, that high force of viscoelastic. Here's me doing one of these. You can see I've gone into the eye with the device here. This is the eye track, and you can see that I'm putting the catheter. It's quite a large catheter into the canal. Now, as you press it through, it's quite tight fit, and you've got to again put it through 360 degrees. Now, it's got a beeping LED at the end, so you can switch the lights off and you can see exactly where you are. Sometimes you might have gone into the AC, sometimes you might have gone into a false path, but that's what you use that for. You can see it's gone around 360 degrees there. Now I'm holding it in place and withdrawing it while simultaneously my nurse is injecting viscoelastic. So it basically expands the canal. In this case, it comes back into the anterior chamber at the end. Here you can see at the end of the procedure, the canal is widened. You can see there's a large amount of blood reflux into that area now. Of course, you can also convert this into a gap procedure by holding both ends and ripping it out as well. And some people do that also for children. So simply put, why I think it's an exciting area is because they're the new kids on the block. But I think the important thing is it's not available everywhere, and in certain countries it's just prohibitively expensive. And if you look at all the results, they're very, very modest. I don't want to overstate the effects of all these MIGs. At the best you're going to get 1 or 2 medications reduction with a similar IOP, and the IOP lowerings are not going to be very much, so they're usually restricted to the more milder glaucomas. But of course, with time, prices may drop. They're never going to be cost effective, especially with generic drugs on the market now. But one thing I do find that's useful from these is that it definitely delays our trabeculectomy use. And even after the 400 that I've put in of these devices, very few are actually needing trabeculectomy after 4 or 5 years. So it still shows that there are some patients, whilst they may be back on drops again, they're not needing trabeculectomy. So I think that's a useful thing in itself. When you learn these MIGs, there is some skills that you can transfer from one device to the other side. So that's also helpful. And what I'd like to see, of course, is some randomized control studies looking at these devices compared to one another. And we should get a better idea of which one would be best for which situation. For example, which one would be best in angle closure, which one would be best for the children's glaucoma. And one thing I've learned about these MIGs is that you've got to stick to the rules. Don't apply the shortcuts, because I've tried and it doesn't really work. Where are we going to go with these MIGs in the future? Will there be concurrent MIGs? Would you bring devices in the trabecular meshwork and also in the suprachoroidal space? Again, we don't know how to max out the trabecular meshwork and then when to move on to the other areas. Will the indications expand? Will it be ever, useful to use this for ocular hypertension? Well, clearly not at the moment because it's too expensive. But who knows with the future costs coming down. And we'll be able to use imaging to find which patients will really benefit from this. Does prior SLT confer any guide to whether these MIGs will be useful or not? Again, we don't really know the answer to those questions. But I think naturally the area will rationalize, so you won't see so many devices around. And of course, hopefully we'll be finding some different reimbursement models that again bring the prohibitively costly devices down in price. Thank you very much for your attention.
Thank you, Dr. Shamira. That was an excellent presentation. I don't know, having all these options, sometimes we feel that you don't have this option, but this can be sometimes confusing which one to use. And learning, and as you said, this all has a long learning curve. So all these uses, we'll get our thoughts from the panelists. Vijayamam, can you hear us?
Yeah, I can hear. Yeah, I will.
Madam, can you hear us? Yeah,
yes.
So there has been a lot of questions to all. There has been a lot of questions, and people have been sending questions and pictures to ask you. I'm just going to share a couple of the pictures, and I will have the questions. Can you see the slide?
Yes, I can.
Yeah. So this has been 2 pictures sent from my colleagues saying that if you have a flat bleb, this looks like a very nicely done surgery with 1 releasable suture and 1 fixed suture, first POD. So what are you going to do?
This is the first post-operative day. How much was the pressure?
First, that they did not mention. They just send me the picture saying that the flat bleb and the first POD. What would you do? I mean,
first post-operative day. Usually, what we do is we measure the vision and we check the intraocular pressure. We will make sure there is no leak from the edge of the fornix. It looks like a fornix-based flap. So when there is not much, if the bleb has not formed, I will not do anything other than doing a massage adjacent to the flap while examining the patient under slit lamp visualization to see how much flow is happening, how much the bleb forms. I'm not in a hurry to do anything on the first post-op day. The pressure can be even high on the first post-op day. Make sure there is a good flow and wait for another 72 hours before you release the releasable suture.
So you would wait for another week to release the
Not
releasable.
week. Usually we call the patient 72 hours later.
Okay.
So that time again, you measure the pressure, see how the flow is. Depending upon the pressure, depending upon the flow, the releasable can be released at that time.
Madam, can we do serial test at this point to see is there any leaking or not?
Yes, I think if there is a leak, your pressure will be very low. That's why I asked you how much is the pressure. And fornix-based flap, however careful you are, if you do the CDLs on the first post-operative day, you will have some amount of leak. So at that, unless the pressure is very low, I will not worry about the situation at this stage.
I would ask Dr. Arif, thanks for accepting our invitation. That what is the preferred method you prefer for releasable suture or doing a laser suture lysis? What's the common practice over there?
I think most surgeons will do laser suture lysis. That's my preference. I think with releasable sutures, sometimes, sometimes they don't bury, and patients can be bothered by foreign body sensation. And I've seen colleagues struggle with pulling the releasable sutures sometimes at the slit lamp. And at times there's risk of breakage of the suture, and then you've lost your ability to modify the flap. I personally am in favor of placing a few interrupted scleral sutures and modifying as necessary postoperatively. For us, our argon laser is just down the hall, and so it's very easy to take the patient and release sutures sequentially to try to modify as much as possible and decrease that risk of immediate hypotony.
I would ask Professor Munir, in our part, we see that we are more comfortable using the releasable suture rather than going for the laser suture lysis. What is your preferred choice, and what do you practice generally?
Actually, I practice releasable suture because it is cost effective for our part. If we see in the post-operative period, particularly in the first week, we cannot achieve the target IOP. It is more than the target IOP. In that case, I try to release the releasable suture, which I usually given in the apex of the triangular flap. And laser suture lysis actually need a costly lens, which is not available everywhere, and also it needs the laser. I think this releasable suture technique is more comfortable for us.
Dr. Pereira, there was a couple of questions that, can you do...
Dr. Ishtek, can I add this point?
Yeah, please.
Regarding the releasable suture, it was my favorite technique, even 3-4 years before. But when I started the argon laser suture lysis, actually I have stopped it. And now I do ALSL, argon laser suture lysis, for my cases. And the patient is not to pay anything because I have the lens and it is in the package of the surgery. If the patient's pressure is higher and I cannot control with digital massage in the first 1 or 2 weeks, then I go for the argon laser suture lysis, and that is include the package. So I don't take any money from the patient. I do it myself. So that is my favorite technique now, to do the argon laser suture lysis in my patient.
Yes, madam.
I just want to tell you, see, trabeculectomy is something you evolve the technique that works best in your hand. So diversity is more common than the uniformity. It's not like a phacoemulsification. I think what works best in our hand is acceptable, provided that we are doing it in a scientific way.
Right.
Yeah.
Are there any difference of the conjunctiva between the West and our part? So, because some of the colleagues in India, when I was doing my fellowship, we used to hear that the conjunctiva is thick and it's not always easy to perform laser after a month or so. So do you find anything, Dr. Shirisha?
Unmute, please. Srisha, Dr. Asha, unmute.
Yeah. So I don't think so. Between Bangladesh and India, I don't think there is any difference. But
we are all one.
But definitely in people in patients from Africa that we get, especially from Nigeria and places like that, they have very thick Tenon's capsule. So that thick tenon sometimes can make it difficult to perform a suture lysis, but I don't think it's very difficult. Whatever works, like what Dr. Vijaya said, whatever works best in your hands is fine. Availability, ease, and your experience. I think all of this will definitely count.
There were so many questions to you, Vijay, Sirisha, regarding the suture materials. Can we use Vicryl for suturing the sclera? They said that it's going to be go away after 6 weeks. So can we use Vicryls for scleral sutures? And is there any pros and cons for using 10-0 nylon or Vicryl during the conjunctiva closure? So two questions were asked.
Yeah. So I've been trying to answer as many as possible on the question answer board there. Yes. So if you ask me, my preference is for the scleral flap closure, we always use a 10-0 nylon. Sometimes I have used 10-0 Vicryl as well, because Vicryl can get absorbed, but not 8-0. Somebody had asked this question, can you use a 8-0 Vicryl for the scleral flap? 8-0 is too bulky and it's also braided. Whereas 10-0 Vicryl is non-braided and it is thin. We can use a 10-0 Vicryl, and Dr. Vijaya has published, and she routinely uses 10-0 Vicryl and 110-0 nylon, I think, Dr. Vijaya.
Yeah, that I use it mainly with the phacotrabeculectomy when I use the scleral tunnel as a mode of trabeculectomy. So the only caution I have, if you are using 10-1 Vicryl alone for closure, it's not a good thing, because when they all dissolve, sudden hypotony can happen. It's always better to, in lieu of releasable suture, using the Vicryl for the one Vicryl suture or 2 Vicryl suture, depending upon them. But it has to be combined with the nylon. Vicryl alone is not a good idea.
And the second part about the conjunctival closure, I think it is fine. 10-0 nylon is something many people use to close the conjunctiva as well. But we use 8-0 Vicryl on a round bodied needle, especially for conjunctival closure. You don't want a sharp cutting needle. So that's the advantage of using a 8-0 Vicryl. And it's also quite strong, especially sometimes if you have conjunctiva, which is very thick, and especially somebody has been on long-term anti-glaucoma medication, this conjunctiva can be very difficult even to pull anteriorly. So if you see, the tensile strength is much more with an 8-0 Vicryl compared to a 10-0 Vicryl. 10-0 Vicryl I use if I have to use a continuous suture for a modified phonics-based flap. That means you leave a 1 millimeter or a 2 millimeter frill anteriorly, especially when you have an anterior scarring. In that situation, because I need to use it very anterior, I can't use a 8-0 round model, can just cheese wire the thin conjunctiva. The more posterior you are, Vicryl is okay because the tenons is thick. The more anterior you are, tenons is very thin or absent in the anterior part. There you obviously cannot use a 8-0 Vicryl. You have to use a 10-0 Vicryl or a 10-0 nylon, whatever works best for you.
There was some questions for Dr. Shamira. 2 questions I'd like to, that can you do only mix, or you have to always do with cataract now?
So
yeah, please.
So I'll just answer that one first. So it depends which region you're in. So for example, in some regions, they are only allowed to be used in conjunction with cataract surgery. In other regions, you can do it as a standalone procedure as well. Generally speaking, the IOP lowering is better with the phaco as well, because you get the effect of removing the lens.
And another question was that, you are saying that, put them apart so that they don't drain the same area.
Yes.
Are there any tests to find out that which area is draining better or which area is draining less, so that you can put the device in the less draining area? Do you have any tests like that?
It's interesting. I mean, that's what we'd all love to know, so we can target the placement of some of these devices. The interesting thing is that the position of the collector channels is probably nasal and temporal, as opposed to superior and inferior. But of course, it can vary massively between patients. I think some of the clues that we have when we position these devices is looking for clumps of pigment. So for example, when you look at the canal and when there's blood reflux in there, you can see clumps of pigment, and we would try to target those areas as that's where the pigment is moving, into the canal. So I think that would be a good place to put it, because that may be where the collector is underneath that. And also when we look at the reflux of blood in Schlemm's canal, we can see sometimes there's discontinuities as well. So if there's an area where it's white, where there's no reflux, we try not to go for that area because we think that the canal may be collapsed in that area.
Dr. Arif, there was a question that what would you do for overhanging bleb? What is done in US commonly? Do you get them very often, or it's very rare in there?
No, it is very common, definitely in younger populations. So if you have a younger patient with maybe trabecular glaucoma, who you've done trabeculectomy for, they're going to be at higher risk for an exuberant overhanging bleb and the symptoms associated with that. I think in my mind, the issue has to do with elevation of the bleb causing disruption of the tear film and subsequent symptoms. And the goal for me surgically is to flatten out the bleb architecture in order to attempt at a more regular tear film. And one way to do that is the beautiful videos that were shown in which the bleb was excised and the conjunctiva pulled down. Now, of course, with that technique, the one risk is of inducing fibrosis and subsequent bleb failure and loss of intraocular pressure control. And so the balance is correcting the bleb architecture while maintaining bleb functionality. My go-to technique has been the compression sutures, large compression sutures over the bleb without excising the bleb, and that cover the whole length and width of the bleb. And sometimes it requires more than one of these in order to flatten out the bleb architecture. Often in these patients, the tenon capsule is so thick that even if you get some early onset leakage, that leakage heals pretty quickly. And then those large compression sutures can be removed later on in the office, maybe a few weeks later, and oftentimes the bleb will have flattened out. Now that doesn't always work, but that's usually my go-to technique, at least initially, to minimize the risk of bleb fibrosis.
I have a question, Dr. Istia. Can I ask a question to Dr. Sirisha?
Please.
Dr. Sirisha, you are well known to Bangladesh. You are the invited speaker in our annual conference a few years ago. So every ophthalmologist, particularly the glaucoma specialist, is well known to you. Some of the surgeon, you nicely described the flap procedure and the stitch procedure for prevention of early postoperative hypertonic. Some of the surgeon during operation use halon into the anterior chamber. They claim that during this halon, it prevents perioperative expulsive hemorrhage prevention and postoperatively prevent hypotension, at the same time well formation of the bleb. After 3 or 4 days in the postoperative period, it is absorbed and IOP to the normal level. What's your opinion to use the halon in this perioperative period? And another question, I know you, the massage procedure, postoperative massage procedure is a very good maneuver for bleb functioning. You always advise it is to the upper lid, but some of the surgeons prefer it through lower lid. What is the advantage of massage to the upper lid? Please, your comment, please.
Thank you for your question, sir. So the first one, Helon, is it advisable during trabeculectomy? I personally don't use Helon. In fact, most of the time we don't make a paracentesis also. So immediately after, so pre-placed sutures for the scleral flap And as soon as we do the ostium, trying and closing it, and we do use cycloplegics on the table as soon as the scleral flap is closed. So by the time you finish closing the conjunctiva, you will see that the anterior chamber is quite well formed. So we don't need to, but yes, sometimes it is possible that we lose the chamber, and paracentesis with balanced salt solution or whatever, ringalactate or whatever we are using without adrenaline is something that we use to reform the anterior chamber. Rarely in certain situations, like if we are doing secondary glaucomas, like let's say spirophakias and things like that, I prefer to use intracameral air. But I don't use intracameral viscoelastic in trabeculectomy patients. Some people do use it in children in congenital glaucoma, especially when you have large ophthalmic eyes, but that's not practice that I follow. In some patients in implants, if I don't want a shallow anterior chamber in certain situations, I leave not heel on, but HPMC in the anterior chamber, but trabeculectomy not. The second question about massage. So it's about whether we are doing the massage. Is the surgeon doing it under a slit lamp visualization, or are you asking the patient to do it in the postoperative period? These are two different things. So if a surgeon is doing a massage in the early postoperative period under visualization of a slit lamp, then of course we do lift the upper lid and then use the upper lid itself as a space for you to be able to do a digital massage, and we will be able to visualize the amount of bleb formation, feel the force with which you need to give the massage, as well as which location is the bleb increasing in size. So that will give you a clue as to which of your tight sutures are tight, which side is the scleral flap not allowing the drainage to happen. So that is why we are doing it. If I have to advise the patient to do the digital massage, I generally don't do that less than 3 weeks, at least until the anterior edge of the conjunctiva is completely healed. I do not ask them to massage by themselves. Later, when I ask them to do a massage, it is usually through the lower lid. So if the patient is doing it, is definitely not they will not touch the upper lid. It's usually through the lower lid, asking them to actually roll the eyeball up and trying to give the pressure on the inferior sclera. I hope that answered the question.
Okay, thank you, madam.
I have another slide. There was a question to Vijaya madam that, when do you open the eye patch after surgery? Do you open it on that day or first post-op day? Because sometimes this picture was sent that first post-op day it was opened and there was severe inflammation. So what is your advice on that?
Okay. It depends, and suppose in a single-eyed patient, if I do I'm more comfortable in not patching the eye when I do the trabeculectomy along with the cataract surgery, because the chances of the shallow AC happening in a combined surgery is very, very remote. The chances of a shallow AC with a trabeculectomy, yes, it can happen. So because of that reason, in single-eyed patients, most of the times I don't patch the eye. And nowadays, majority of my surgeries are with a modified technique of a minimal injection in the inferior quadrant. It works like a topical, but it takes away the pain. So because of that, in single-eyed patients, I do not patch the eye unless I suspect there is a possible leak and there is a threat for any other complication. Usually after 2 hours, start using the topical steroids. So it all depends upon the clinical situation and also how comfortable you are to take that step.
Okay. Thank you.
Can
madam.
I add to the suture when you have a hypotony, what do you do was the question, and whether to use the heel-on or not.
Yeah.
So in a situation where we anticipate hypotony, like in high myopes, you don't want to close the scleral flap too tightly with the sutures and then end up with the high pressures and manipulating the sutures in the postoperative period. In such a situation, my practice is to take the apex releasable sutures and 2 base sutures. So with this, if still the eye is soft and anticipate hypotony is likely to happen, I take the vicryl sutures for the rest of the closure that will take care of the immediate hypotony. At the same time, in 3 weeks time or so, the vicryl will resolve and allows better blood formation. So you can avoid using the Helon. You can form the antechamber well with a good closure using the vicryl in addition to the tenonylon.
Thank you,
Yes,
madam.
please go ahead.
Yeah, so this was another picture. I would go to Dr. Arif do you know, needling, when is the earliest time? Say this is a 15 POD patient with a flat bleb. There's little chemosis and 2 reducible suture, and after, so if this was released, the releasable suture, but still the bleb did not raise. So what did you do in this sort of situation after 15 days?
I have not needled that early on. Usually I do wait a few months. You know, if you have a flat blab, I'm assuming that the pressure is high. You know, one point to make here is I would want to maybe do some gonioscopy to assure that their sclerostomy site is patent and that there's nothing obstructing the ostomy site. Here, you know, I would probably still continue with massage at this point. I haven't needled this early on. You know, I'd be interested to hear from the other panelists, but assuming that the sclerostomy site is open, I'd probably continue with ocular massage.
Yeah, I would like to hear from Professor Vijaya and Srisha also. This was sent with a question that, you know, after 15 days, the surgeon removed the 2 sutures, but, you know, he just felt that there was no superficial flap. There was totally fibrosed after 15 days. So he has used mitomycin for 2 minutes, 2%. So what to do now? That was his question.
I think what he said, that Arif said, is that you have to make sure there is no closure in the, maybe you have to put in the gonio lens and make sure that opening is sufficient enough. Give a little massage and see how much bleb is forming, how much the pressure is coming down. To me, I think there is a lot of congestion. The vessels are very prominent. I will not go on releasing the sutures. See, what is happening is when you have this kind of angry looking bleb, the fibrosis is happening. If you release the suture, the pressure will come down. Because the bleb is angry, the fibrosis will continue, the pressure will not come under control and the bleb will not form. So what we have to do is we have to control the inflammation that is happening. So make sure that the good flow is there, the bleb forms with the massage, control the fibrosis. Go ahead with the 5FU injections. Give 1. If needed, more than 1 you have to give. And wait and see what happens to the inflammation. Once the inflammation comes down, if you release the whatever releasable suture still there, I think that will help. Needling is too early to do. It is only just 2 weeks. I think it is too early. What you have to do here is to control the inflammation, then release the rest of the sutures. Advise massage if patient is able to do it, if that is helping. And wait for things to settle down before you go for the needling.
Dr. Shirisha, your take on this one, that, you know, 15 days, it looks that there was no trabeculectomy done, you know, flat bleb after 15 days, after removal of the releasable sutures.
Yeah, so I definitely agree with what Dr. Arif and Dr. Vijaya had just shared. But what I'm not able to understand is what if the 2 releasables were released, what are these 2 additional sutures?
Yeah.
It's possible that multiple sutures were placed and right from day 1, the drainage was not much, and hence it's actually going in for fibrosis from the beginning. And then also added to that, there's a lot of inflammation. So if the drainage did not happen right from day 1, I've had one patient like that who had a neovascular glaucoma and I had done a trap, and day 1 pressures were extremely high and they were releasables, but I didn't obviously want to release releasables on day 1. And I had a lot of difficulty in massaging because patient wouldn't allow. he would just not allow because he was extremely sensitive and the lid was edematous in situations like that. So what I did was I took him up to the minor theater and I did a massage with a speculum on. So use a bud to just go posterior to the scleral flap, and I did a massage there. And then once I dipped the posterior flap, beautiful bleb formed, and after that things were all right. So sometimes when the pressures are very high, after you have ruled out the ostium block and things like that, the pressures are very high. I'm talking about early, less than 1 week, where if you don't allow the bleb to form at all, it's going to fibrose. It's going to just completely heal, and not allow the fluid to filter. But at this stage, 15 days, these two sutures being intact and two releasables released, I'm not sure if the filtration has actually happened at all. So I would agree 5FU injection, and then we need to understand what the first 2 weeks situation was, and based on which, suppose it is not filtering at all, and the first 2 weeks also the pressures had been high, then I actually don't mind going and releasing that one additional releasable that is there. Maybe leave behind just one suture and then see how things are with a massage and 5FU injection.
Okay, thank you. I have two questions for Professor Nazrul. That one was from Dr. Ruhi and another was from Dr. Ashraf. That what quadrant would you place the GDD? And Dr. Ruhi has asked regarding pars plana implantation of the tube.
Okay, thank you very much for the question. First of all, I have shown it is the superior temporal quadrant. That is very easy to do it, and most of us, we try to do it. But definitely, we'll have to examine the conjunctiva. Here the conjunctiva, there is no scarring, the mobility is good in the supratemporal area, then that is the best site. But if we have the history of retinal detachment or history of silicone oil in the anterior chamber, then usually we avoid the upper quadrant. In that case, we can go to the lower, the infratemporal or infranasal. But in the other cases, if we have good conjunctiva and mobility is very good, definitely supratemporal quadrant is better because it gives better cosmetic value. It does not have any restriction of the rectus muscle also. So I prefer the supratemporal most. And second option is the pars plana tube. Yes, sometimes if the antechamber is very shallow, there is a lot of peripheral synechia, 360 synechia, and we cannot do the anterior chamber tube. In that cases, definitely we can think of pars plana tube implant. But condition is that the patient must have vitrectomy. If the patient do not have vitrectomy, our retina colleague should do the vitrectomy first. That is important. And second important is your plate should be a little bit posterior. And even in the tube entry should be a little bit posterior so that it go to the pars plana. And another thing is the tube inside the pars plana should be more than 3 millimeter. Usually we make the 2 to 3 millimeter in the anterior chamber, but for the pars plana, it should be a bit longer. I would request Dr. Shirish also to comment on this because as Dr. Professor Monir said, that Dr. Shirisha, Dr. Bijoy came several times to Bangladesh and they had a lot of contributions for doctors. And personally, I learned many things from them, from Dr. Bijoy and Dr. Shirisha. I would request Dr. Shirisha also to give the answer, something else if you have, please.
On GDD, that where do you place the primary?
Yeah. On this question, please, yeah. She had a lot of experience.
Thank you, Professor Nazrul Islam. So I think you answered all that I would like to say as well. So supratemporal quadrant is the preferred choice. And if that position is not available, if that location is not available, either especially in encircling patients with encircling bands, where you have an overlapping band sitting there and you don't have space, or because of extensive scarring or extensive synechiae, and you will not be able to place the tube in an appropriate position in the anterior chamber, then we choose the other locations. The followed by supratemporal, if that is not the choice, then it is the infratemporal, especially for Ahmed glaucoma valve. Nasal, because of the large blebs that they form, you would prefer not to use. But in situations where you have no choice at all, then obviously if I'm doing a nasal, supranasal or an infranasal quadrant implant, that means I'm forced to do it, then I will use a smaller sized implant. FP8 is something that I use, and I don't use a larger sized implant if I'm doing a nasal location.
Yes.
But for an ADI, it is different. ADI infranasal is quite convenient to do. It's easy to do also because especially the oblique muscles don't come in your way, and it is very easy to identify the muscles. And of course, because of the low-lying bleb that they have, it doesn't really cause much of a problem. So supratemporal, if not, it is the infranasal for an ADI.
Yeah, Madam,
Thank
Vijaya,
you.
Madam wanted to add something.
Yeah, I think when it comes to the inferior, I always prefer the inferior nasal, even for the Ahmed valve. Fortunately, I didn't anticipate any problems for the simple reason I think cosmetically it looks better. Inferior temporal, usually cosmetically it is not an appealing situation. Patient can feel that the bulge in the inferior temporal quadrant. So inferior quadrant always better to do a inferior nasal rather than the inferior temporal.
Patient usually say foreign body sensation in the inferior temporal. Yes.
Dr. Arif, what percentage of your glaucoma surgery would be trap and mix? You know?
Yeah, it's an interesting question. You know,
Also bulb, also the
Yes.
drainage device, yeah.
Yes. You know, I've gone with our population, similar to many of you, we work in a tertiary care center. Many of the patients are high risk, have had prior trabeculectomy. Really, in my practice, the percentage of trabeculectomy has gone down to maybe 15% or so, and I've become much, much more shunt heavy, Beervelt and Ahmed valve, much more with the Beervelt shunt. You know, I think that's probably the most frequent glaucoma surgical procedure that I perform in my practice. And then in terms of MIGS procedures, it's of course, as for all of us, a growing proportion, and my go-to MIGS procedure has been the Cahook dual blade, which, you know, I find, at least for me, gives the best efficacy for intraocular pressure control. And, you know, for a patient with well-controlled glaucoma who has a cataract, it's a very easy decision to proceed with a MIGS procedure to try to aid in long-term control at that point.
Do you do glaucoma drainage device in primary, you know, other than refractive glaucoma, just POAG? Would you, you know, many of the American surgeons prefer that?
I do.
As an initial surgery,
As initial surgery, I do. I am, you know, guided by the primary tube versus trabeculectomy study. And now in those cases, it's going to be a Beervelt shunt, which gives you higher efficacy than the Ahmed valve. So it would be a primary Beervelt shunt. And, you know, in a younger African-American patient who's going to be at high risk for trabeculectomy failure, I think a primary Beervelt shunt is a good option for us.
Dr. Arif, I have a question. Can I ask one question, Ishtiaq?
Of course.
Yeah, please.
So, to you and Dr. Pereira also, that one of our doctor came from USA and they have taught us the Cahook dual blade surgery. So definitely they give some blade also, and I have done 4 cases, and 2 cases did better. In the another 2 cases, they needed the anti-glaucoma medication, and 1 case needed the surgery. Definitely there is a learning curve. There is a learning curve. I am not that much acquainted with this, but what is your experience that Cahook blade surgery gives the good result in your experience, you and Dr. Pereira also, in your practice? How percentage of people actually gives very good decrease of IOP with KDB?
You know, it's very interesting, and I think there is a little bit of a learning curve to it, but even once you're past your learning curve, there's a lot of variability in outcomes. And I definitely have a fair share of patients where there's minimal to no effect from the Cahook blade or other MIGS procedures, but there's other patients that have a significant effect, and it's kept them from needing more invasive glaucoma surgery. And in all patients, virtually, it tends to be a safe procedure with very minimal risk of complications. And so the way that I have my conversations with patients is I'll say something like, just like Dr. Pereira mentioned, under promise, and I'll say, look, I can't guarantee that this will work. I can't guarantee that this will keep you from needing more invasive surgery, but it could, and I'll quote a percentage of maybe 50% or so. And I'll say, you know, it may be worth that chance given that it's such a safe procedure. And if it works, great. We've kept you from needing a surgery at least for a few years. That's the conversation that I have with the patient, but ultimately my results are just as variable.
Okay. Dr. Pereira will comment.
Yeah, I mean, I totally agree with that as well, actually, because I mean, especially with the KDB, I use it for a particular set of patients. Remember I said that I look at the angle and decide on which MIGS to use. So if there's a lot of iris strands, any PAS or a short distance between the scleral spur and the iris, I try not to do this because there's not much room to maneuver with the KDB. If you go too far upwards, you cause a DM detachment. If you go too far downwards, you will cause the iridodylisis. So I think I pick my cases like that. But in terms of the final result, I think the problem with the KDB is that there is some damage to the back wall of the canal. And especially if you haven't got it quite right, that's the problem that can happen. And exactly right, you know, some work very, very well and some it's like as if nothing happened.
Thank you.
So I think, yes.
Dr. Stek, can I ask one question to Dr. Pereira?
Please.
Dr. Pereira, can you hear me?
Yes, yes.
You nicely present different MIG procedure, internal MIG procedure. We are interested about this, but the main barrier is its cost. Most of the device are $2,000 to $3,000. Our common people cannot afford it in our country. So far, I know there is a device Gen cellular instant Gen procedure. It is Gen implant, collagen implant. It is a blood forming procedure, and it can reduce intraocular pressure lower-tin. And we can use also mitomycin C for improving the blood function. What are the advantages of this Gen procedure over the trabeculectomy? As because both procedures are blood forming procedure. If you got my point, what is the advantage of this Gen procedure over trabeculectomy?
Right. So I mean, you're exactly right. You described it very well. There's two actual procedures. There's the PreserFlow device. I don't know if you've seen that one. That's by Santen, and there's Zen by Allergan that drain into the subconjunctival space. And no one has yet done the study or randomized control study of either of these devices versus trabeculectomy, or the results are not out yet. Okay, but of course these are very expensive devices, and they will probably not do as well as a trabeculectomy. The advantage of the Zen is that it's ab interno, it's very quick to do, and you're doing everything ab interno, so there's no risks of any like conj leaks. But of course, you suffer all the risks of any bleb forming procedure. So you're right. You know, there's very limited amount of advantage, especially if you're paying, you know, that amount extra.
Yeah. Thank you.
We were talking about ostium being blocked with iris tissue. So this was a patient who was operated abroad and was doing very nice, but did not adhere to the advice and flew very early. And after coming here, the pressure was high. So what is the preferable time that after the trabeculectomy patient can fly, or do a bus journey or train journey? Yeah, because we have a lot of patients going to LVPI, Shankar Nethralaya, and this very patient was operated in Singapore National Eye Hospital, and the release note was showing that he was doing very well, everything was, but they advised him to wait for the 10 days, but he just flew after 3 days. So what is the minimum time that we would require?
What procedure was done?
Trabeculectomy.
So if with the trabeculectomy, travel should not be an issue. Because people do travel in 3 days, 4 days time. Well, unless the PA was not sufficient enough, because if the PA was not sufficient enough, if the PA has been missed, this kind of things can happen. But I don't think it is linked to the travel. unless you have used a gas which can expand and cause problems. I'm not sure why a travel can produce a situation like this.
So
if I can
what is
just
the
add, so some reason why sudden hypotony could have happened, where there is gush of fluid that goes through, along with which, especially if you're using cycloplegics in the postoperative period, the iris tissue can actually go and block the ostium. So shallow AC, sudden hypotony in the postoperative period, either because you're talking about travel, either lifting heavy weights or straining themselves, or some kind of a thing must have precipitated this problem. That's the only thing I can think of. But I agree with Dr. Vijaya. So there should be no restriction for travel. But yes, whether you're traveling or whether you're sitting in the place that has been wherever the surgery was done, precautions in the post-operative period, I think, is equally important.
a very common question that when patients can bend down. This is the most frequent question I hear from the TRAB and all the
I think, yeah, the definition of the bending down has to be appropriate. Bending down to eat food and look at the book or reading a book is perfectly all right. Bending down to do namaz or pray, definitely for 6 weeks, I would say not to do it. Below the waist, bending down below the waist is usually we tell patients not to do that.
I think we are nearly at the end of our time. So last question that, if this shallow AC PI was done and the AC was very shallow and pressure was high. So would you do a trap only because that would shallow the anterior chamber more, or combined in this case? This was a question sent by Professor Zakia Shohid. Also, she had asked that, in this COVID era, people are not wanting to travel. So if a PSA is diagnosed, would you put on PILO or push them for LPI for travel to other city?
The PA was done. It is only just PACS.
Yes.
It is only primary angle closure suspect.
Yes.
Why there is a need to do the surgery?
Pressure is still high.
So that means it is a PSC or PSC. How old is the patient?
It's not PSCS.
That they did not totally send. It said that after doing that still. So would you do?
You may have to rule out why the pressure is high.
Yes.
One, if the in presence of the patent PI, if the pressure is remaining high, there is a need to look at the gonioscopy to rule out the plateau iris syndrome.
Yes.
And what is the cause for the rise in the pressure, and what are the how is the angle? Does it open up with your compression? If there are no synechiae, then you have to, maybe UBM will help you to see what is the configuration it's having, how is the ciliary processes. If you take it, the patient is fairly young, and if you suspect a plateau iris syndrome, a pilocarpine will make a lot of difference. And also you have to look at how is the optic disc, how is the visual fields, before you take a decision to go for the surgery. I think jumping to the surgery just because the pressure is high, we can end up with more problems.
Dr. Ishtak, I want to ask one question, if you allow.
Please, sir. Last question.
I have a question to Dr. Shirisha. Dr. Shirisha, actually, you have wonderfully discussed about the scleral flap and the suturing. So in case of open angle glaucoma and angle closure glaucoma, do you think the difference of the scleral thickness, that is half thickness, it should be different thickness? And regarding the tightening of the sutures, in the angle closure glaucoma, we want there should not be any leaking. The AC should be open, should be formed. So we make it more tight. So is there any difference on the open angle glaucoma and angle closure glaucoma trabeculectomy for the flap thickness and for the tightening of the sutures? This is your comment.
Thank you, sir. But I don't think I really changed the thickness of the flap in any type of surgery that I do. Like I said, the prerequisite is dependent on the patient's scleral thickness. So let's say it's a high myope or somebody with a problem with the sclera, having collagen vascular disease and things like that. There you will have to alter based on the pre-existing thickness of the sclera or scleral thinning that you see. But otherwise, I generally don't alter the scleral thickness. Flap closure is, yeah, of course, in angle closure patients, you would want to be a little more careful with the filtration. You don't want any shallowing because already the eyes are shallow, have a shallow anterior chamber. So the tightness of the releasables is something that maybe you would want to work on. But any releasable that you place, if it is not tight, then there is no point in putting a releasable there. So I would look at it this way. Do you put one releasable versus two releasables? Or do you place the suture very anterior, closer to the edge of the scleral opening, or slightly more posteriorly? Maybe that positioning and the number of releasables is something that I would look at. But essentially, even in open angle glaucoma patients, it's the same. But what I would change or differ in the way the medications intraoperative, cycloplegic, definitely we use it at least 2 to 3 times before I completely close the eye. Subconjunctival atropine is something that I always give along with the steroid injection at the end of the surgery in angle closure patients. So this is something that I definitely follow, because these eyes, you need strong cycloplegia to prevent the shallowing precipitating a malignant glaucoma.
Thank you. I think I have one question to Dr. Ishtiaq. In your presentation, you showed that in some cases, even you use the MMC, the people are doing the tenonectomy. I just heard in your presentation. So I differ, because if you use MMC, then tenonectomy will make very thin conjunctiva that will rupture. So I want the answer from all panelists and speaker, of course.
I said that there were surgeons using MMC and doing tenonectomy. That's why we have some overfiltrating bleb. I don't personally use it. I just said that the cause of overhanging bleb was because 6-7 years ago, surgeons were using more concentrated MMC for duration was more, and even sometimes combining with tenonectomy. I personally don't do it.
So is it really, I want to ask, know from the panelists, that is it really possible that if you do use the MMC, you also do tenonectomy?
Actually, I never do it in anectomy. So,
Yes.
I mean, it's I never do it in anectomy. On the contrary, I try to protect the tenons as much as possible.
Yes.
I also have not found tenonectomy to be helpful.
Yes. That is the message actually I wanted to give, because if we use MMC, never touch the tenos capsule.
I personally don't do tenonectomy ever. I never have.
Yeah.
Okay, so we are at the end of the today's webinar. I
Can
thank.
you share? Okay.
Yes, I just with the invitation for the next week, we have refractive surgery, and I just want to thank Professor Vijaya, Dr. Sirisha, Dr. Samira, Dr. Arif, Professor Munir, and Professor Nozrul Islam for being with us and teaching us all these things. And you have been always with us, and I thank you all.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you.
And also thank you, Dr. Ishtiaq, for organizing such a good webinar. Thank you very much, everybody.
Definitely, we are grateful to our guest speakers and panelists.
Thank you, Dr.
very much. Thank you very much.
Stay safe.
Thank you. Very nice to see you after a long time.
Yeah.
And Dr. Pereira and Dr. Arif, we want to see you in Dhaka.
Oh, definitely want to.
Thank you. Thank you very much.
Thank you.